afternoon, everyone. As we mentioned earlier, the approach of cardiomyopathies usually is trying to divide the cases whether what you see is in the line of differential diagnosis of hypertrophic cardiomyopathy or dilated cardiomyopathies. As you may see here in this case, the left ventricle is hypertrophied, dilated left atrium, more or less function is preserved. Let's go to the short axis again to show the hypertrophy of the left ventricle. It's more evident along the septum. RV is also mildly hypertrophied. Three-chamber view showing again the hypertrophy of the left ventricle. However, there is no left ventricular obstruction, outflow obstruction, and there is no regurgitation or aortic stenosis. There is no SAM. The hypertrophy more or less is symmetrical, which makes HCM less likely. The patient from history was not hypertensive, so hypertension is also excluded. And the clinical question targeting the MRI was to exclude amyloid disease. And when the clinical question is about amyloid, usually the most striking sign would be in the T1 scout that we do usually before giving the contrast to perform delayed gadolinium enhancement. So it's the same slice acquisition in different times of inversion, and as you may all know that different tissues has different inversion time, which allows to nulling of the different tissues in order to detect and see abnormal patterns of late enhancement in the myocardium. Usually, or in normal subjects, the blood reach the nulling point before the myocardium. So in normal subjects, the blood will turn black and dark before the myocardium. So let's see whether this kinetics applies in this case or not. Yeah. So if the blood gets darker before, I'll just move to the correct side. So now let's try to focus on whether the blood will null before the myocardium or is it the myocardium before the blood. So this is the first image, second, third, and maybe on the third image we could all see that the nulling point of the myocardium is before the blood. So the next slice you would see that the blood now turned black, and this is an abnormal kinetic, and this is very striking to the diagnosis of amyloid disease of the heart. And if we move toward the late enhancement of the short axis, we would see a diffuse late enhancement in whole myocardium. It's not territorial, but it's rather diffuse, involving all myocardial segments, mid-wall, or in some areas maybe almost transmural. Diffuse again, late gadolinium enhancement. And sometimes, and one of the very striking signs also that you would find and see in amyloid disease, rather than any other differential diagnosis, this subendocardial layer of late enhancement in the atria, more evident in the left atrium. Sometimes you would see hypertrophy of the right atrium or the left atrium as well, but enhancement of the left atrium and the abnormal kinetics in the T1 scout are very striking to the diagnosis of amyloid disease. Maybe in this case also try always not to forget to check the extracardiac finding. So there was some changes in the lung